When I first stepped into the clinical life world to study physician burnout, I wasn't entering as a fellow doctor. I approached this as an educator and a qualitative methodologist, an informed outsider looking in. Like most people who read the literature, I arrived with a specific expectation. I assumed I would hear a standard narrative dominated by endless charting, administrative bloat, and crushing patient loads. But that assumption carries a glaring logical flaw. If clinical burnout is merely a symptom of systemic overload and bad scheduling, then adjusting a physician's hours should be an easy cure. Broad summaries of surface-level complaints provide a catalog of grievances, but they miss the interpretive layer, the specific meaning these physicians attach to their exhaustion. To get past the surface, I used a specific qualitative tool, Interpretive Phenomenological Analysis, or IPA. For this study, I applied its individualized strategy. The core rule of this strategy is strict isolation. You must complete the entire analytical cycle for one physician's transcript before you are allowed to look at a second case or attempt any comparisons. This diagram illustrates how the method forces the researcher into a practice called bracketing, actively holding back workload expectations. The filter catches the obvious complaints so that smaller, unrecognized anomalies can slip through for inspection. Working this way is demanding, but it is the required investigative tool to expose the exact details that broad, generalized surveys ignore. Take the first isolated case, a 37-year-old physician I'll call P1. When asked what caused her burnout, her response was surprisingly terse. She gave a short, clipped list of tasks, almost keeping the painful dimensions of the experience at arm's length. But her answer about how she coped was dense and rich. The heaviest analytical weight in her entire transcript rested on a single word she used when describing her desire for peace: again. This single word "again" carries significant weight. It implies that a state of peace existed before the exhaustion took over. If peace was the starting point, then burnout represents a disruption of that personal history. It transforms the experience into a sense of theft, the loss of an original baseline. Consequently, recovery requires restoration, an active reclamation of the self that goes far beyond the benefits of mere rest. The most analytically demanding transcript belonged to P4. She was the youngest participant in the study, with only 2 years of experience, and she reported experiencing burnout every single day. Yet paperwork was not the primary culprit. P4 was exhausting herself performing the daily emotional labor of overcoming patient skepticism. As a young African-American female physician, she faced a credibility challenge written on her body before she ever spoke a word. There is a strong temptation in research to smooth over these outliers and absorb them into a broad category like workplace stress. I actively chose to preserve this distinct embodied divergence. The moments when a participant's lived reality strongly resists an emerging framework are the exact moments where the analysis yields the highest value. Then there was P3, a 70-year-old physician with 35 years of experience. He posed a completely different challenge because he barely experienced burnout at all. He created distance from the phenomenon by framing it as a hazard for younger physicians. He noted that without the right mindset, a doctor could easily fall. Fall is a highly specific verb. It moves the definition of burnout away from simple fatigue and recharacterizes it as a dangerous loss of professional footing, a structural collapse. His account proves that clinical burnout is not a fixed, universal constant of the medical profession. It is a highly dynamic threat that hunts for specific vulnerabilities. Only after honoring these individual accounts in strict isolation did I lay the 5 theme tables side by side to look for cross-case connections. My initial expectation of systemic overload was replaced by a different universal finding. Every single physician in the study consistently attributed their burnout to external forces. Identifying that doctors blame external factors is a pattern. Making meaning out of that pattern requires understanding why they do it. This externalizing framework functions as an essential form of professional self-protection. This universal pattern reveals a deeper architecture. Clinical burnout functions as a profound struggle to maintain a coherent professional identity. The administrative and scheduling issues are the external pressures that make this internal identity work so exhausting. A timeline graph reveals a clear trajectory. Year 2 is defined by the acute vulnerability we saw with P4. Moving to mid-career, this evolves into complex restorative needs. Finally, at year 35, we find the near-total absence of burnout, replaced by hard-won structural autonomy. This progression maps directly onto a single vital metric, a physician's gradual accumulation of professional agency over the lifespan of their career. Solving complex crises like burnout requires moving beyond systemic generalizations. We must commit to the rigorous, individual interpretation of lived experience.